as you might expect, and underwent and completed his medical education at the University of Perugia. He did a fellowship in Master of Surgery at the Imperial College in London, and at that time his master's was determining the effect of CRP on myocardial tissue damage in myocardial infarction. I don't know if you're aware, but the training in the UK is extremely competitive, and registrars are very competitive positions. Dr. Griselli was able to do his pediatric and adult congenital training with 3 superstars. He studied partly with Dr. Magdi Yacoub at the Brompton, and then he spent 18 months at the prestigious Birmingham Children's Hospital working with Roger Mee, who most of the pediatric cardiologists recognize as one of the premier cardiac surgeons in the world. After that, he took a position at Newcastle on Tyne at the Freeman Hospital. Again, the UK is a little bit different than we are in that there are centers that are specified specifically for particular reasons, and only those centers may do those treatments. And so this was a center for pediatric heart and lung transplant, one of 2 in the country, one of 4 centers for ECMO in the country, and one of 2 centers for VADs, or ventricular assist devices. With his work in adult congenital, he developed Freeman Hospital to become one of the centers in the UK that was able to do transplants for adult congenital patients. He'll talk about his transplant results today and show you that they're even better than the American results on the ISHLT website. During his time in Newcastle, he took a sabbatical and went to Paris to study under Pascal Vouhet at the Necker Hospital to learn the techniques that he employed for doing difficult infant cases. After his time at Newcastle, he became the senior attending surgeon in pediatric cardiology at the King Faisal Hospital in Riyadh, where they do more than 900 cases a year. He began work on ventricular assist devices for single ventricles with colleagues in Sheffield, England, and Milan, Italy, and he's brought that research to the United States. He continues to be interested in this topic, and since 2012, he's published more than 25 papers on VADs and transplants in children. So it's my distinct honor to welcome Dr. Griselli to our institution.
Thank you very much, Dr. Bralin, for the kind introduction. I want to just tell you something regarding my career. Before going to Newcastle, I didn't know anything about heart failure in children. I basically start everything from there. And this presentation I want to share with you is not a lecture or any teaching. It's just to share with you my experience during my time there, what we done there, what we built up at my time I was in Newcastle. So it's nothing, like you want to lecture you on anything. It's just to share my experience. Talking about heart transplantation, you know very well the first transplant happening in the 6th of March 1967, and then very, very few people know that just 3 days after there was the first pediatric transplant. And this has happened basically in a child. Epstein was transplanted heart taken from an anencephalic baby. You can see it's been done on circulatory arrest at 15 degrees in an ice bath, and the chart which I show you is stopped abruptly because the child died. The first few years of heart transplantation results were not as good as we have now, and basically this was 1968, 69, and 70 across the world. So this brought the public opinion to have this release in journals like the tragic record of heart transplantation. But the resurgence was very close and started with thinking that we have to go through failure, as Winston Churchill said, without lose the enthusiasm. And from this molecule, we start the resurgence of heart transplantation. And this is what you can get very easily from the SHLT database, is what we're doing now in adult and pediatric transplantation. We are more or less across the world around 5,000 transplants per year, as is shown on this table. And this is the pediatric heart transplant based on the recipient age distribution. Over the last few years, there is a steadily increase in number of transplantation, nearly 700 across the world. And this is regarding the age of the people and children get transplanted, vast majority below 1 year old, and more or less across an even distribution, which you get really more towards 16, 17 years old, where the weight of the children can allow usage of an adult donors. Who we transplant, basically the diagnosis in any stage of life is mainly a congenital heart disease, although there is an increasing number of cardiomyopathies, particularly because now the diagnosis is easier and we can support these babies. And across the years, we get that the cardiomyopathy group is increasing. This is 6 to 10 and again, and this is 11 to 17. Again, the dilated cardiomyopathy represent the vast majority of these patients. Regarding my experience in the United Kingdom, beside all you know about happening in the world, Professor Magdi Jacob did the first heart transplant in the UK at Hayfield, and Chris McGregor, who's now the director of cardiothoracic surgery at the Middlesex Hospital, now performed the first UK transplant in Newcastle. And that is the girl that was transplanted. We invite her to for her 21st birthday at the celebration for our 800 non-transplant at that time. In Newcastle, it started 33 years ago, in 1985, the program to date. And this is a very recent date, is 982 transplants performed and more than 200 in a pediatric population. This is the number released by UK NHSBT, which is basically the transplant in general body which governs the transplantation in the United Kingdom, related to the transplant number done in the United Kingdom over the years. How we go and organize the transplantation? Now, United Kingdom is based on 2 hospitals, which is basically Freeman Hospital and Great Ormond Street. This is a common urgent and common non-urgent waiting list. This is basically taken from the urgent waiting list. The babies are basically listed by in a temporary. We basically get the referral, we assess them, we sometimes and seek for a second opinion, and then we put on a waiting list. And on a waiting list, we basically specify the group, the age, and basically the restriction, and what we're going to do a transplant if you're ABO mismatch, and so on, will be specified. Each of these baby, particularly for the Freeman Hospital, will have also independent child specified who's going to do a transplant, who's going to retrieve, and so on. So for these babies, we start with the referral data. We look at the blood results, the anatomy, if it's different and if it needs attention, the function, the physiology, the pulmonary vascular system, particularly transpulmonary gradient, and we do also dental assessment and make sure that everything is in order. But most important is for transplantation is make sure the families are on board of what we're going to do. So the comprehension of what the transplant entails, the ability to understand the medical instruction, the compliance with the medication, and family, they have coping skills and the support for these babies. And this I want to show you this, not just the name, but make attention to how many people are involved in a transplantation. And this is just heart transplantation. It's not just a surgeon with just 2, but all the other people make a big difference in the results for this group of patients. So it's very important to understand that transplantation doesn't involve, create transplantation one day to another. It's historical, it's the biggest department in each hospital, and not just for heart transplantation. Then we go into a transplant conference where after we had the opportunity to assess the patient, so we're talking about the underlying diagnosis, the severity of the prognosis, and also if there are possible alternative strategies, This exercise has been done several times in adult congenital, not particularly in pediatric population, because the lack of donors. So we try to do operation to avoid the transplantation. And what if looking at the factors when influence the outcome, which is the pulmonary vascular resistance, the antibodies, and the function, end organ function, renal, liver impairment, and other psychosocial difficulties. At the end of the discussion, we can list, defer, or reject for transplantation. And then, if we accept, we have to define the strategies, the organ type, the size, who's taking care of this patient, the clinical status can be urgent or non-urgent, and how can be easy to find a match for these patients related to the age, weight, HLA, ABO, and so has to be defined a tailored harvesting for the transplant. So far is good, but then this start to have what is not very good in transplantation. This is the offers we had in the last few years in Newcastle for an organ less than 30 kilo. And this is a very disturbing chart because the offers has really gone down. I can see it's minimal amount of offers. And this 30 kilo, we talking about patients we can transplant up to 20 kilo and so on. So really reduce our chance to transplant many children. And you can see even this, the number of transplant in United Kingdom is decreasing across adult and the pediatric population over the last 10 years. And this, because we have so many patients on the waiting list, some dies on the waiting list. This is from a journal from Scotland reporting that our patient may die while waiting for a transplant. I want to show you two papers done from Freeman Hospital and Great Ormond Street across 10 years. And this was done in 2003. I wasn't in Newcastle yet, but this was basically showing how the children were transplanted and the median waiting time to transplant these patients. Very short time, near 2-3 weeks, and they get transplanted. So short time. So what we can do if a child is sick and we have this kind of offers, we use ECMO. ECMO is something we become very good in it. 30 years of experience, we can deploy in an acute setting, and it's good also to support the renal function, the pulmonary function, and so on. But it's a short-term support. It's invasive. It does the heart completely because it increases the afterload. So it needs some time to be vented in the septostomy. It needs also lots of resource intensive because normally 2 nurses. Children need to be paralyzed, sedated, and associated with a serious complication, which start to come between the second and the third week. So beyond this time, they're not good. We repeat the same exercise I said to you 10 years after, and you can see at the bottom how to receive an organs between 5 and 10 kilo. In a child for 5, 10 kilo, 10, 20 kilo, we need to wait on average of 90 days. So there's a game is changed. So how we can supply this? And then we look specifically at our patient in Newcastle. This is the waiting time to wait for a transplant when we are on mechanical support. So ECMO is not good anymore, so we move to this. So then we start to use mechanical support in terms of ventricular assist devices. It's these 3 children in the summer 2014 outside of the Freeman Hospital with the HICUS, we supported with the Berlin Heart. What we try to achieve with the mechanical support is a bridge to transplantation, to recovery, to decision, and to destination, which probably is not accurate for children, except from some kind of, I would say, program like my friend in Rome at the Bambino Gesù does for Jarvik program for Duchenne children. There are basic requirements for this VAD is that they're applicable across all the age groups, and size is compatible with the congenital heart abnormalities, so different anatomies, its capability to biventricular support and compensate for the growth of the children. And, I'm very jealous about the adult surgeon. They got so many devices, and, this is just few of them. And then, but for us, we have at the moment just this. And this Berlin Heart is a very good device. We can support children, 1, 2 ventricles, from neonatal size to adult size. And we done a good experience in Newcastle. We done basically, at the time I left, at that time we done 116 Berlin hearts, plus other devices which were implanted at the same time to support the pediatric population. And we become the second unit in the world outside Berlin to produce in the numbers of Berlin hearts. You probably remember, most of you, this paper is done for FDA approval of the Berlin heart in the United States. And this basically was a usage of a compassionate usage of a Berlin heart in patients with cardiomyopathies. And what did this show? A disturbing number. It is this. It is basically that at least 1/3 of the babies will develop a cerebrovascular accident of any sort. And that is not a nice number, okay? You thinking about a child, 3 will have some kind of stroke. It's not nice to think about. When we've done this and look at our statistics in the United Kingdom, we have a little better results, but not much better. So 1 in 4, we have a stroke of any kind of entity. So there was a strong desire to find another device, and maybe particularly looking at what the adults doing, and this was the James Kirkland 5th Intermax report. Their incident stroke is much, much less. And this was with a heart-to-air and HeartMate at that time. Really, really much small. So why we can use their device as well in some children. And this was the Oliver Mera published this, and to use the heart-to-air in a pediatric population. This was the report. At that time, we already done one in Newcastle. This child was supposed not to suitable for transplantation due to a very strange cardiomyopathy related to the muscle dystrophy. But eventually we transplanted. We assisted him for 94 days. He did very well on the heart-to-air. So there was an effort, from everywhere in the world to try to use the machine because the better results, and particularly less complication. So we pushed the limits down. So we then down to 13 kilo, and the child with myocarditis was supplied with an heart-to-air. You can see it takes almost the whole left side of the chest. And the cable was so long, we had to wrap around the heart because there was no space. So this is made a page on the local newspaper, and eventually, because the heart recovery was a very bad form of myocarditis, it was decommissioned. And this is here when it was decommissioned. Basically, the machine was still there. We just disconnect the cable and tied off the outflow graft. And it's next to a child who, for poor compliance, basically needs a device, which was another heart-to-air, after rejection for transplantation. We basically extended this experience, heart-to-air, across this group of the patients, and sometimes, and this was a major mistake, to do an HVAD in a patient with a restricted cardiomyopathy. It never worked, and basically we had to put a temporary form of mechanical assistance on the right side, which remains throughout the assistance up to the time of the transplantation. And there's some complication in the transplantation related to a cerebrovascular accident. And the way we used to do this is basically put an heart-to-air and then a temporary, I would say, minimal invasive form of RVAD. You see the inflow cannula is basically on the neck, and the outflow cannula is basically through a graft which goes through the ribs, inside the chest, attached to the pulmonary artery. The chest is formally closed. So when we want to win the RVAD, we just basically put this cannula and tie this graft here and push inside the chest. So without reopening the sternotomy again. And we push this role of this non-continuous flow pumps to several children, which basically did very well on this machine. Unfortunately, they tried with an MVAD. MVAD in heart-to-air didn't have the same good results as the HVAD, so it's never been really in any place used as much as the HVAD. So despite this problem related to the donors, the number of transplants increased, and it's increased particularly because we had the usage of mechanical cardiac support. And they can see in red those patients which will be supported with the VAD, ECMO, or what else before transplantation. And this is reflected also from SHLT data, and you can see increasing number, a percentage and number of children going to transplantation with mechanical cardiac support. Technically, as operation, most of the time, transplant is an easy operation, big sutures, and can be done either with a bicaval approach or biatrial approach, but sometimes there are issues because we have a previous operation, and operation the cardiologist never seen, surgeon never done. I've seen some operation I've been through, like I never done an atriopulmonary fontan. They had a multiple thoracotomy, sternotomy, and this abnormal venous return, either systemic or pulmonary venous return. So don't surprise that sometimes I had this, because I'm going to a patient and I had to say, this is what happened, this is your anatomy, that's what we're going to do. And this is extremely complex to do this transplant sometimes, particularly after several operations before. But we done well. This was the statistics of the Kaplan-Meier survival on under 68 transplant, which we've done very well over the years. And also getting better over the years. This is ERA survival approach, looking every 3 years, and it's been reported from UK Cardiothoracic transplant audit. So we're getting better, not just from the surgical point of view, but particularly from the post-perioperative care. And this is very important because Claire Herfing, when he was with us, put this related to how was our results related to the pathology. So between congenital heart disease at a single or two ventricle compared to cardiomyopathy. And we noticed that over the years, now the results are exactly the same. So I would say that the years was in Newcastle and even in Great Ormond Street, results of transplantation in children with congenital heart disease or cardiomyopathy are exactly the same. Things change later in life when, of course, patients with a single ventricle physiology have a worse results, and I'll show you later. Now we got also this, that's why we get better. We got a great number of drugs which we can use. We've been lucky to have at Newcastle Dr. Kirk, who is now in Dallas, who took care of this patient with this great number of drugs which I have available at this time. What's the complication? Of course, we know rejection and infection, particularly the renal function, neurological dysfunction, and of course, long-term chronic graft vasculopathy. We transplanted, I said, particularly cardiomyopathies compared to the congenital heart disease, and this was the age distribution of the patient. Of course, babies between 10 and 17 have a more chance to have an organ, the fact that they can take, as I said, an adult-sized organ. And this was the diagnosis, and I show you exactly that, particularly in children, the hypoplastic left heart syndrome represented the vast majority, together with a single ventricle, double-hilled left ventricle. So if you look at the congenital heart disease across all the age group, what with in adult we transplanted mainly TGAs, and we're talking about previous operation like master descending. We not do this operation anymore. What we're doing now in arterial switch. So we don't have anymore this group of patients, or at least they're getting less and less. And in pediatric population instead, hypoplastic left heart syndrome represented the majority. How we can increase the donor pool because we get such shortage. And this lady, Dr. West, did a major impact in our field by the usage of AB incompatible heart. And this basically is related to the principle that the AB incompatible heart is safe in young patient without circulating anti-donor antibodies. And that's what we're doing recently, in recent years. But I have to say something. This study, the groundwork of the study, also from Newcastle, these two immunologists show the effect of lack of response on antibody during the transplantation to the polysaccharide antigen. It's something completely different from an immunological point of view, shows some energy of some children present at early stage of life related to this antibody response. And this was the important background work for Dr. West. So we started an ABO mismatch program in Newcastle with the first in February 2000. And basically we had reported also our multi-center experience with no mortality or acute rejection after an ABO mismatch transplant. Also, what we start to use and then sometimes take unusable donors, and particularly for those children who are thinking that they're in trouble because they have no good outcome with mechanical support. And I show these three patients here, one on BIVAD with a multiple cerebral infarct, so the second, And the other one was a child with hypoplastic left heart syndrome after the Glenn stage, who was inotropic dependent, tracheostomized, so they needed heart very soon. So that we picked up something nobody wants. And this was the 3 hearts with a very poor fractional shortening, but this was happened after we rescued them with ECMO soon after transplant. So the cause of death post-transplant are mainly acute rejection and primary graft failure, and together represent more than half of our basically cause of death. How we can do to avoid this? We have some tools. Yes, mechanical circulatory support can be very useful after transplantation. And this was Dr. Perry, when he was with us in Newcastle, reported this of 15 patients with rescue with the mechanical support after transplantation, either because early graft failure or rejection. And this was the graph we reported, and some of them, they've been also retransplanted with very good results for retransplantation. 4 on 4 were survived. 1 died again later because of lack of basically compliance with the medication, and probably was the reason why he required another transplant anyway. The other challenge is mainly the HLA antibodies, how we tailor immunosuppression for these children, and the vasculopathy in long term. So what is sensitization, what the children receive over the time, why we develop some antibodies, which we need to take care when we choose an appropriate organ. So we had some what we call Luminex test, look at how many antibodies the children have and how we can choose the organs appropriate related to the antibodies. And then how we develop a sensitization, particularly blood products, particularly platelets, white cell, also the pregnancy, the mechanical support, and for the surgical point of view, is the use of homograft, which very often, and I use very often in repair for congenital heart disease, and also previous transplantation. And this is a paper report by Dr. Ross, who will basically show how we develop more antibodies related to the usage of homograft in patients. And we use commonly for reconstruction the heart in hypoplastic left heart syndrome, so it can be a reason to develop antibodies. And this was a classical tissue typing on a teenager who came us for hypoplastic left heart syndrome at the Fontan level with 85% of the donor unsuitable. And what this implies, that basically we have a very reduced donor pools, which is significant fall in donors' numbers, many the prospective cross-match, and increasing time on a waiting list, which basically can be also fatal for this. So many of these patients cannot be transplanted. But unfortunately, we find the organs we basically desensitized before, and this is a picture playing cricket a few months after the transplant. So we have several drugs. So this is the pathway as antibody production, and now our physician have plenty of drugs which we can intervene and for desensitize this patient. But of course, there's also a possibility to antibody removals with the plasmapheresis, immunoabsorption, and this can be preventative therapy for acute rejection, or we can treat with this with the plasmapheresis, immunoabsorption, even as a rescue therapy for acute rejection. And this is exactly show the graph of a patient who basically underwent immunoabsorption, and you can see in a late rejection how the level of antibodies has been dropped by the usage of this technique. Of course, the other agents I'm not going to spend on you because this is beyond my expertise, but of course this MMF and IVIG, plenty of usage of this, and eculizumab as a monoclonal antibody has been employed in some patients. And this was what we done in 4 patients. In 3, we have been very lucky and be good to have a success in reverse the acute rejection. 1 child unfortunately died, but he had also an ABO mismatch, not just HLA mismatch. And despite to put back on Berlinart for 2 months, we could not basically go against this inflammatory response, and also was not suitable for retransplantation in view of the unsuitability of any other organ. This is one of the success girl we had she was desensitized, she had 99% unsuitable donors, and we successfully then transplanted. So this was the assessment we do with the HLA at the referral. We do Luminex test screen. We assess if it's suitable for transplantation or not, and basically we decide if the number of antibodies is very strong, we may desensitize or not list at all. And this will be the management. It's very important to get what is called the CD positive or negative, which tells you exactly which the killer cells are around the body, and then treat accordingly for these results. There's something we're not doing too well, and I'm going through a little bit. This is because also, for me, it's very important because it's part of my research. You know very well what's happened with a single ventricle baby. Single ventricle is basically those children which don't have such a malformed heart, which is only one pumping chamber. So only one ventricle. So that's what we call single ventricle circulation. Commonly, these children are going through 3 operations to achieve what is called the Fontan pathway, where basically passively through conduits or to direct connection, our venous system drain in the pulmonary arteries, and basically the heart just supply the systemic circulation. And this is basically the Fontan history from Francis Fontan developed this kind of palliation for these children. But we know very well that this is a very short time palliation over the life. At some stage, the children require, or adults require something more. Of course, this is where there's some evolvement to make this palliation better, and important was basically the fenestrated lateral tunnel. This was developed by Marc de Laval at Great Ormond Street, also Aldo Castaneda at Boston Children's Hospital, and Carlo Marcelletti at Bambino Gesù had this idea of the extracardiac anastomosis, with the graft between the IVC and the pulmonary artery, which avoided some problem particularly related to the arrhythmias. But Fontan is very common to have a Fontan failure, going across failure, an early failure, which is a high mortality, with the intraoperative myocardial injury, with systemic venous hypertension, with elevated pulmonary vascular resistance. Sometimes we have to take down what we've done during the operation, and also the AV valve regurgitation, arrhythmias, or probably ventricular dysfunction. Late failure is just what we see in most of our patients with the systemic ventricular failure, develop what we call a protein-losing enteropathy, and plastic bronchitis, again arrhythmia, thromboembolic event, and so on. So, lots of problems with these patients. So the pathway to transplantation is as a hemodynamic failure, collateral damage, mainly the pulmonary arteriovenous malformation, and protein-losing enteropathy, or protein-losing bronchopathy, which is called commonly plastic bronchitis. There is some operation. One was Dr. Mavrudis, when he was in Chicago, he basically popularized this type of operation, was the total cardiopulmonary conversion of a previous atriopulmonary operation, plus arrhythmia surgery. This was a good operation, but now it's restricted to very few cases when there's a mechanical problem and when it's an arrhythmia problem. And there are not many in the group of the Fontan failure patients that we can operate in this way and convert to a different form of the Fontan. And the survival of a transplantation with Fontan operation is different very much between the two populations. And as I said to you before, the results of a pediatric transplantation in these children with the Fontan failure is exactly the same we have across the age group, even with the congenital heart disease, with the cardiomyopathy. The problems start with the Fontan in adult size, an adult group, because basically there are more problems related to the end organ function, particularly the liver, so it's a long term. So what we try to do with transplantation, replace a heart, but is a body disease, it's no more just a heart disease. So what we have in a single ventricle? In single ventricle, we have an isolated pump failure, systolic or diastolic. We can have an isolated Fontan circulation failure with very high pulmonary vascular resistance, but most often a combination too, because it's like a vicious circle happening in the body. So what we can do for this? Put a VAD? Yeah, I think the idea, this is an electrical circuit which basically resembles what is a Fontan circulation. And yes, this is a child who basically had a gland after single ventricle reconstruction. We can use a VAD. But what can be the results of this? I give you all the literature relating assistance, mechanical assist devices in a single ventricle. And I can give you single cases, series report, this country, Europe, and I review all of them. If you put together the statistics, tell you the survival is 50%. So 50% is poor results. Compare what we can do in two ventricle circulation, which is now is 90%. And when I was in Newcastle, we look at our data was about 10 patients and 10 children, and with 50% mortality, no better. And particularly, the one survived, they were lucky to receive an organ. So just alive by chance. So we're not doing very well. What we done ECMO was very good. The 3 on ECMO survived because it's good at the post-total caval pulmonary connection. It's almost impossible to do an ECMO in a child after caval pulmonary shunt because it needs a sternotomy or thoracotomy. It can be used as a bridge to decision, but as I said to you, ECMO is just a short-term device. So we try to do the VAD, and this is a VAD, as I showed you before, in a child with a Glenn, and they were done in 5 children. All this after BT shunt again. And in this case, I have to basically reduce the size of the shunt because it was over shunting. So the QP, QS, as we say, the blood going to the lungs compared to the systemic circulation was in excess. But we had several problems. This is just a list of the most common. There are many more. So inadequate emptying or filling, central venous pressure was very high, still inotropic dependency, end organ failure, still ventilated despite the VAD, hypoxic, developing large collaterals, so basically inability for support in medium long term. So I will tell you that if somebody comes here and tells you, I can support a single ventricle long term, don't believe him, because it's not possible. Okay? So this is a failure, and for a doctor, for us, to absorb the failure is difficult. So what I try to attempt solution, this is a change atrial cannulation, said the drainage will be better. Put a BIVAD, so reconstruct like a 2 ventricle circulation, put a bigger pump, smaller pump, put an ECMO together with a VAD, transcatheter occlusion collaterals, everything you can come in your mind, we try to do it. No good. Actually, some of these babies had to go from VAD back on ECMO because we couldn't oxygenate them. They have a poor also function, so basically failure. Okay? 5 on 6 died of this. So that's why across the world there is a very strong research indication towards this group of the patient and can take different direction, which is lump parameter models, basically mainly a computer program, computational fluid dynamics model, hydraulics models, and animal models. For myself, I took basically the mock loop circulation to look what we done wrong at the time of implantation of this VAD. So I reconstruct the VAD circulation, and this is at the time of the Glenn, and very easy to show because basically the Berlin heart ICOS is very good in that because it's got 2 ports, one from the LVAD, one from the RVAD. So I use one for the native heart and one for the pump, which is supposed to be the VAD. And this is the circulation. You can see this is the IVC resistance, SVC resistance, pulmonary circulation, aortic circulation, and this is pumped through this. So I use a 15 cc bigger pump as a native heart, and then a 10 cc as a VAD to assist the native heart. And I had to do some things to put some data. How to basically put the data. So I took the results of 20 cardiac catheters done in Newcastle in children before Fontan, so at the Glenn stage. So they're perfect candidates for a Fontan. And we basically tailor the machine based on this data. And it's done like this. So Glenn pressure, aortic pressure, transpulmonary gradient, common atrial pressure, based on catheterization done in patients that subsequently had a very successful Fontan circulation. And I had to do also this kind of, I had to make a hole in the Berlin heart pump to mimic the apical cannulation to make sure that it was exactly as we done. And what happened on this? I've done also atrial cannulation, by the way, just to make sure that everything was put in the experiments. What the observation? I won't go through the experiments, there's so many, but there was a gradual deterioration of the VAD performances in a pure Fontan failure and a mixed type, like a real clinical setting. And there was a lack of beneficial response, increasing pump pressure, pump size, rate of suctioning, or everything we're doing, no better. And there was also worsening of arterial pressure and transpulmonary gradient in pure Fontan failure and mixed type. So the response of the VAD was limited to preload and afterload condition. So actually what we see, we give them more blood, it's pumping more, we increase the afterload or preload, we modify the VAD response. And essentially, this machine we use, and sorry to say this, a stupid machine. Well, we fill them up, they're pumping, but they're not sensing anything else in the body. So this only responds to fluid management, a systemic peripheral vascular resistance, pulmonary vascular resistance, and that's it. So basically, we need a VAD which is clever enough to understand the single ventricle physiology. That's why we don't have now. That's why everybody wants to have. So there are some direction. So we have, for example, Rodfield, which developed the impeller pump inside the Fontan circulation, like support the Fontan. Some other people, like Berlinart, try to experiment a cannula, which allows to have two ventricle circulation. You can go in different directions. So that's what's basically the problem. So we need to search more, that's called research, and in a way to have a device which will sense what the body does. So, in conclusion, I want to tell you that cardiac transplantation is a good treatment option for children with heart failure, but the shortage of donor has increased the need of mechanical cardiac support to bridge them to transplantation. We have robust strategies to increase the donor pool and support the patient after transplantation, and also just a word of caution, have a very careful selection of the patient with a failing Fontan circulation, because we cannot support them. So we need to list before we think of other patient. I know that will increase the number on the list, but it's the only way to get them through transplantation. Thank you very much.
Thank you, Massimo. Thank you, Massimo. It's a great talk. I'll start out with a simple question because most of this went right past me. The drop-off in available donors in England, what was that associated with? Because it looked quite precipitous over a short period of time.
Well, I really don't know what was so precipitous. Okay, you have to see also the ethical problem in different countries. So, for young donors, in England, it's not possible to harvest the heart before 6 weeks of age, because we can't technically have a proof of before that. So, all transplants done before 6 weeks using donors were from other countries, Italy, Spain, France, and so on. So, long distance. I don't know why there was such abrupt changes. I don't know what happened during the years. When I read the paper Weinstein done in this country on a single ventricle, if you notice, there was here as well that the patient on single ventricle were transplanted within 3 weeks. So there was a change as well in this country at the same time. And this has happened across the world. So maybe they are more done, so we get the less number of donors, they're more distributed, and that's what's happening. So that's what's the problem. I mean, there have been big changes. I mean, we've been waiting for months on these VADs.
Thank you, Massimo. That was really a nice presentation. You know that our fetal cardiac program is one of the robust program almost in the 3 states. My question is, there are times when families approach to me for single ventricle patients, should I save the cord blood? And my answer is, I don't know. What do I do with this? And I'm sure there's a role in future. Do you see anything?
There is a role for in the future. I'm not an expert of this. We try, talking about cord blood, we try to get a program for this. Mainly because of the surgery. Makes a big difference surgery, because of the quality of the cord blood, not just the stromal cells, but also the quality of blood in terms of for hemostasis and so on. So it's something in our mind, it's something which has been already discussed. And there probably will be a future for this, for sure, for the stromal cells, but I don't know in which direction. Need to have a very robust program for this. It's just, it's a very important topics of this, more than beyond just a very good science behind that.
Interested in the differences in the stroke rate between the two assist devices, the Heartwear and the Berlin. Is there any rationale that one, that you can see that one does something different that puts kids at risk versus the other, and why we see that difference?
Well, it's just because the refinement over the years of the pumps is completely different, and Berlin Heart is a pulsatile device, and it's complex because it's got two system of valves inside, which basically make the system a little bit more complex compared to the centrifugal pump or the continuous flow pumps. So they're much more refined. And over the years they get better, even in that sense. But this is intrinsic in a problem in a pulsatile because they need valves. And that's it. Then the valve, inflow valve and outflow valves. That's the issue. And created other barriers across. Plus, the Berlin Heart has got a lot of connection, and it's a paracorporeal, so it needs to have a tubing to come out of the heart and come out in the chest and go back in. So all this tubing with the connection anastomosis contributes to have possible points to creation of thrombi that can go in circulation. That's the issue.
Thank you.
Thank you, Dr. Griselli. I really enjoyed that. There's been a lot of conversation in pediatric cardiology and cardiothoracic circles over the last couple of years about the ultimate failure of the Fontan pathway for patients where 20 or 30 or 40 years down the road, they all require additional support. They develop liver dysfunction, liver cancer, et cetera, et cetera, et cetera. And certainly before the invention of the Norwood procedure, the primary therapy for patients born with hypoplastic left heart syndrome was direct infant heart transplant. Do you see, as we advance the technology and expertise in management of VADs in infants, a role for moving away from palliative strategies for hypoplastic left heart syndrome and instead putting assist devices or bridging infants to heart transplant directly with these technological advances?
It's absolutely right. That's something we start in Newcastle. So every child born with an hypoplastic left heart syndrome or equivalent was basically put in a double path, so listed immediately. And if you will get an organs within a chance that the child will survive, otherwise it will go through the Norwood procedure. So at the time I was born, I represented, we put an offer for a neonatal heart. If you get in the time we can wait before surgery, fine. If we couldn't, we had to do the operation. And it's happened, it's like it's a dual pathway. And we all discussed with the family that will go. 2 patients like this were fetally listed because there was so much tricuspid regurgitation and was not suitable for any surgery. Unfortunately, one, we had to do the surgery, but then was transplanted, and the other died soon after birth. So that's the thing.
Transplant, we've got 20 back, and they're all 20 years old now.
You have been disconnected from the meeting.